Hello, sedation in regional anesthesia. It is truly necessary, or are we something creating unnecessary risk? Today, I will show you two real clinical scenarios. If you are ready, let's begin. Should we give sedation or not? This is one of the most common questions in regional anesthesia, and the answer, it's dependent. Let's look at two different patients. Case 1. A 45-year-old woman, high anxiety, needle phobia, shoulder arthroscopy, a procedure that may last around 19 minutes. And she tells you, "Doctor, I'm really afraid of staying awake." In this situation, sedation may improve comfort, cooperation, and the overall patient experience, not because sedation is mandatory, but because this patient may actually benefit from it. Now case 2. 28-year-old man, calm, no anxiety, cooperative, short ankle arthroscopy, and he say, "Staying awake is completely fine for me." And so, do we still need sedation? Maybe not, because sometimes less is more. Avoiding unnecessary sedation may help preserve neurological assessment, maintain safety, and promote faster recovery. Here's the key message. Sedation is not a reflex. It is not a routine checkbox. It's an individual clinical decision. Right patient, right dose, right monitoring. That's what creates safe sedation. Now tell me in the comment, would you sedate case 1? Would you sedate case 2? And why? Now let's look at comparison between giving sedation or not giving sedation in regional anesthesia. In which situation is sedation useful? Who actually benefit from sedation? And when might avoid sedation be the better choice? The next question is, what level of sedation are we aiming for? The goal of sedation is not to put the patients to sleep, but to maintain comfort and safety, or target minimal to moderate sedation. Based on the articles and references presented, I will briefly summarize the recommended sedation drug dosages and the purpose sedation algorithm. So, who do we decide whether to sedate a patient during regional anesthesia? Not every patient needs sedation. The first step is simple. Assess the patient, the procedure, and clinical goal. If the patient is calm, anxiety is low, and the procedure is short, and neurological assessment is important, sometimes minimal intervention is the best intervention. In these patients, oxygen, monitoring, reassurance, and communication may be enough. But what if the patient is anxious, not fully cooperative, or the procedure is expanded to last longer? Now we may consider light titrate sedation. Several options exist. Low-dose midazolam can help reduce anxiety. Dexmedetomidine infusion is useful when the one cooperative sedation and minimal respiratory depression, and propofol infusion offer flexible titration and rapid onset of required care for monitoring. Remember, the goal is not deep sleep. The goal is comfortable, safe, controllable sedation. Next scenario, the patient has poor pain tolerance. Positioning is painful, or a tourniquet will be used. Here, sedation alone may not be enough. We often need an analgesic component. Options may include propofol combined with small dose opioids such as fentanyl, or low-dose ketamine, which can improve analgesia while maintenance hemodynamic stability in selected patient again. Drug choice should always be individualized. And finally, no sedation strategy is complete without proper monitoring. Continuous monitoring of saturation, oxygenation, EKG, blood pressure, and respiratory. Be prepared for airway or hemodynamic complication. Use the lowest effective doses, titrated slowly, and reassurance frequently.